Well, good morning, and thank you everybody for joining. And it's a pleasure to be here. I'm Dr. David Sykes. I'm in Boston, Massachusetts, in the United States, and I'm delighted to talk to you today about a very, very rare disease called the TEMPI syndrome. This is an ultra-rare plasma cell disorder. It's characterized with an elevated erythropoietin and other paraneoplastic features. And again, thank you for the invitation to speak. Just one word about myself. I'm a doctor in Boston. I see patients only 1 day a week, and I spend some time in the hospital 4 weeks seeing patients with hematology problems. And then otherwise, I'm in the laboratory where I would like to study white blood cell development and really rare hematologic disorders like the TEMPI syndrome. So what is the TEMPI syndrome? And here we made up a little graphic to talk about this very rare disease. Right now, we think we have 27 patients in the entire world with the TEMPI syndrome. I'm sure there's more out there, but we've only identified 27. And it's characterized really by 5 features. Telangiectasias, those are the abnormal, of course, blood vessel development, mostly on the face and the upper torso. Elevated erythropoietin and erythrocytosis. And we can come back to this. This seems to be a really salient feature of this disease. A monoclonal gammopathy, and that's of course the abnormal antibody, the M spike. And then in many patients, but not all patients, we get these very unusual collections around the kidneys, perinephric fluid collections. And then as the disease progresses, we get this very unusual intrapulmonary shunting. And we think it's the same type of process that's happening on the skin that's happening inside the lungs. And you're getting shunting of blood past the lungs. But how did we even get here, right? This is an ultra rare disease. So I want to spend a little time talking about the first patient, describing this new disease and how we sort of understood it. And then also spend a little time thinking about how to treat patients with TEMPI syndrome and maybe some very interesting research directions and ways in which everybody can collaborate. So the first patient we met back in 2008, and I was in training still with my mentor, Dr. Eyal Attar. And this was a gentleman who had been to many, many doctors for many opinions, and then he came to see us for another opinion. And he was generally feeling okay. He'd had a little bit of diabetes. And then you can see there back in 2001, people had already noted that his blood counts were getting high. And so they actually started him on a program of phlebotomy where they would take blood out. Then shortly thereafter, he was noticed to have a monoclonal gammopathy. And then the telangiectasias started on the face. And then he had a couple other problems with a blood clot in the jugular vein. And then ended up getting these very unusual, as we said, fluid collections around his kidneys. You can see that almost took 10 years or 8 years between those, so very slowly progressed. He was born in Tennessee. He had 3 children, worked in real estate, but otherwise fairly unremarkable social history. And actually his parents were both alive. He had a healthy sister, healthy brother, and so a very unremarkable family history as well. When we met him, he had multiple telangiectasias all over the face, in the mouth, on the lips, but very interesting that it was only on the upper torso, nothing below the waist. I have some pictures of the telangiectasias here. You can see some of them are quite clear, some of them are a little smaller. And they were present all over the back as well, and the arms, and even on the hands. His chemistries and his laboratories were pretty normal, except you can still see, even with the phlebotomies, his hematocrit was still 55%. And this is very striking. For all the hematologists out there listening, you can see this is more than 100 times normal, the upper limit of normal range. And this is way higher than even patients with erythropoietin producing tumors, for example, very, very high. And then this is very important because, of course, the patients do not have polycythemia vera. And of course, polycythemia vera, you have a low erythropoietin. But many of our patients have been misdiagnosed with polycythemia vera. So as mentioned, he had started having the erythrocytosis even many years before we met him. And you can see here, look at the progression of his erythropoietin level. Started off pretty normal and then very quickly got very high. And when we saw him, even some of his values were more than 10,000. He had developed this monoclonal gammopathy, but he did not have any features of multiple myeloma, and none of our patients have any features of multiple myeloma. Here, just to give a few more specifics, the size of the monoclonal protein was right there, 0.79 grams per deciliter, but the free light chains were quite normal. This is the immunofixation, just to demonstrate again, it's an IgG kappa protein. And this was no real reason to do this, but we were curious and we showed that it was an IgG1. Now, in other patients with the TEMPI syndrome, these have been IgAs, and even some would suggest maybe one other Ig, but this is probably not important, but an interesting finding. And then he had developed a little bit of ascites and then had abdominal CT scans and ultrasounds showing this large fluid around his kidneys. And then in his doctors had also tried to drain this, just put a needle in and remove the fluid. But every time that it was drained, the fluid just came right back. And here are just some CT scans over the years. And you can see here, this is a pretty normal scan with the kidneys. And I don't think I see any fluid around there. And then you can see it starting to accumulate. And then here you can even see it by the time 2008 comes around. It's all around, surrounding the entire kidney. And in many patients, it actually surrounds both kidneys, but very peculiar how that takes place. And there's just an enlarged version of all of this fluid surrounding the kidney, and then a little bit on the other side. And a magnetic resonance image of that as well. And we decided also, like the other doctors, to try to drain it and get a sample of that fluid. We still don't know why, but it's kind of interesting to look at the composition of the fluid. Look at that. So this is almost identical to his serum. So it's really just like the same composition as the serum and the fluid around the kidneys. Of course, there's no protein. And there's no cells. That was important as well. It's not lymph fluid. There's no triglycerides, but very interesting. It looks just like the electrolytes in the serum. So we did a bone marrow biopsy, and we put a drain to try to drain out the fluid around his left kidney. Now this turned out to be a mistake, because with the drain in place, he was producing 2.5 liters of fluid would come out the drain every day. So he ended up having to be admitted to the hospital because he was pouring out so much fluid from the drain. And we had to give him fluids back, of course. And ultimately, we had to have one of our urologists take him to the operating room so that they could drain the fluid into the abdomen so it could be removed. So instead of having fluid around the kidney, now you have fluid around the kidney that was producing ascites, and then that would have to be removed or reabsorbed, back into the body. So this worked, but the poor gentleman now was having all the fluid draining into his abdomen and accumulating in the abdomen. So of course, we were very puzzled by this case and had never seen anything like it. And so back in 2010, we'd asked Dr. Nancy Lee Harris. At the time, she was editor of the case records of the Massachusetts General Hospital. We'd asked Nancy Dr. Harris if she would present this case as part of the New England Journal, and she agreed to do that. And so you can see here, these were all the people involved in the case. I presented it. This was my mentor, Dr. Attar, and we didn't know what the answer was, but at the end of the case, Dr. Harris was nice enough to put in, she said, we request that anybody with any thoughts would contact me or any of the authors. And what was remarkable is within 1 week, I had 2 emails, one from the University of Southern California and one from Antwerp, Belgium. And Dr. Wilfred Schroens, who's now a colleague and friend over the years, he had a patient, he said, I have a patient exactly like your patient. And Dr. Casey O'Connell, as I said, the University of Southern California, an expert hematologist there, she said the same thing. We've had this lady who's had these symptoms for many, many years and no one's ever known why. So now all of a sudden, we seem to have people that had these very similar symptoms. This was the patient from Antwerp. You can see these telangiectasias are even more striking on the skin, very, very striking. But I think what we also realized was that the microscopic shunting in the lungs was going to be the problem. And so the patient in Belgium was actually having a lot of problems breathing because so much of the blood was getting past the lungs. Now, this is a scan that I did not know very much about until about 10 years ago. This is a macro aggregated albumin scan, but it basically says how much of your blood shunts past the lungs. And of course, very little of our blood should go past the lungs, right? So it should all go to the lungs and get oxygenated. And so the normal shunt fraction should only be around 1%. But in our patients, you can see the TEMPI patients, they can have shunt fractions of 15 to 25%. So a whole 1/4 of their blood is bypassing the lungs and not getting oxygenated. And hence, that's of course a very clear reason why their oxygen levels go down. So with the identification of these other 2 patients with Dr. Schroens and Dr. O'Connell, and we found what we thought were 3 more patients in case reports that had just been published in the literature, we thought, well, this looks like there could be a syndrome. And that's when we published this as a letter to the editor in the New England Journal back in 2011, just on the basis of those 6 patients. Now, what's kind of fun is I just updated this yesterday, is we now seem to have about 27 patients. Not everybody is confirmed. And I'll show a nice paper that just came out of Blood Advances this year from some of the first patients identified in China as well. But looks like it's kind of all over the map. There does not appear to be any sort of geographic preference or anything like that, but very interesting. So, of course, now the problem was we had patients with a disease that was super rare and we didn't know how to treat them. But one of the things that really stands out in these younger people in their 30s and 40s and 50s is that they have an MGUS, a monoclonal gammopathy. And of course, in young patients, that's pretty uncommon, right? So the idea that they all have an MGUS was even more uncommon. And we thought, well, maybe the plasma cells or the MGUS was actually what was causing the disease. So the question was, could the TEMPI syndrome be treated? And so after much discussion with the doctors, Dr. Schroens and Dr. O'Connell, and myself and the patients who were very, very understanding that we weren't exactly sure what was happening, we recommended a course of treatment to try to kill off the plasma cells. And lo and behold, we had remarkable responses to, in this case, bortezomib. This was a group also just down the coast of the National Institute of Health and our patients. And what was remarkable is you can see that the telangiectasias completely disappeared on the torso and the lips. The fluid with treatment with bortezomib completely went away after 8 cycles. And you can see here the erythropoietin level, which was so high after these delivery of Velcade, bortezomib, came right back down almost into the normal range. So this was very satisfying and suggested that somehow the plasma cells and the monoclonal protein were somehow involved in driving the telangiectasias and the erythropoietin. We also had patients that were treated with more aggressive therapy. You can see here, same resolution of all of those telangiectasias. Really remarkable disappearance. And then this was a group in St. Louis that published something similar. It's not the best picture, but they had a nice response in their patient also to bortezomib. And again, these beautiful resolution of their perinephric fluid. We still don't know, of course, what the cause of that is, but nice to see it reversible. This is another patient. And so here in about 2015, 2016, we were starting to get some sense of who would respond, and actually of the patients that were treated. And of course, not every patient has required treatment, but in the patients who had been treated, most of them had either a complete response or a partial response to plasma cell therapies like bortezomib. One patient at the Mayo Clinic actually went to transplant, and we actually took our patient to transplant as well with a melphalan-based transplant. So what do we think now? The syndrome appears to be completely reversible, which is fascinating. Those symptoms all parallel, all come along with the disappearance of the monoclonal protein. And I think a lot of people have asked, well, is this something you're born with or something that's congenital? And I think the answer is very firmly no. This is an acquired disorder that people develop, and then it can be completely reversible. So then the question is, of course, are these patients cured? And the patient in Belgium, after her 8 cycles of bortezomib, had a long, long remission where we weren't entirely sure, but unfortunately she was not cured. And 5 years later, the erythropoietin started to increase, the MGUS recurred, the skin telangiectasias actually recurred, and her oxygen levels started to go down again, which was very concerning. And then our patient, the one from Memphis, he had gone through much more treatment and he'd never achieved a complete remission, which was very discouraging. And then he was actually also starting to do worse. But along that time, the new medication daratumumab had just been approved. That's, of course, the anti-CD38 antibody that was approved for multiple myeloma. And so we thought, well, let's try to ask the company whether we could get some anti-38 monoclonal antibodies, some daratumumab, because these poor patients were not doing well. And then this was very satisfying. We're just using daratumumab as a single agent. You can see here in both patients, their hematocrit came right down. In both patients, it eradicated the MGUS. And in both patients, the erythropoietin came right down. Really remarkable response to single agent. So, of course, this is a tiny number of patients, so you can't really make any firm recommendations. But if I had a new patient with TEMPI syndrome, I think I would automatically reach for daratumumab. So now what? Now we have a problem. Well, so now, of course, you try to get some good advertising. So we made a small Wikipedia page just so that if anybody around the world thought that they saw patients with TEMPI syndrome, they at least would have some references. We registered ourselves with the Office of Rare Diseases, but that's, again, just to help get awareness out there for this disease. And then we were lucky because the 2017 fourth edition of the World Health Organization classification system included TEMPI syndrome under plasma cell neoplasms with associated paraneoplastic syndrome, like the POEM syndrome. So this was good. And I think this has actually been very helpful because now it's helping people recognize what to look for, especially with the combination of hematologists and pathologists. This has been very helpful. And now also interesting, and of course not just related to the TEMPI syndrome, but to other disorders of monoclonal gammopathies, there's been a couple of very cool review articles. This one called Monoclonal Gammopathy of Cutaneous Significance, and basically all of the skin problems, the dermatology diseases that are associated with an MGUS. And then this was another nice article about monoclonal gammopathy of clinical significance, and looking across many different disorders of kidney problems. You can see here some very rare disorders, some of which I've never seen, but very rare disorders. But again, all associated with a monoclonal gammopathy. You can see Dr. Dispensieri. She also summarized this at ASH, I guess now last year, and mentioned the TEMPI syndrome here. And then, of course, we all want to know what's causing it. And I think this is when everybody can be very helpful. So this was a paper actually that came out of, here you can see University in Wuhan and the University in Beijing, where they identified 3 patients that they thought had the TEMPI syndrome. And here, and I can't show all the data, but please look it up. It's in Blood Advances just from this year, actually this spring. You can see here that they were able to show that serum MIF, macrophage inhibitory factor, serum MIF seemed quite high in the TEMPI patients, quite high in the bone marrow of TEMPI patients. And these authors, it looks like they've also been studying MIF in the context of multiple myeloma and normal control. So it's interesting to see that the TEMPI syndrome patients are much, much higher than the normal controls and are somewhere in the same range as the multiple myeloma. So they were suggesting maybe MIF was important, very interesting. And then I want to show you just a couple minutes of what we've been doing in my lab, along with a lot of good collaborations. And this was just a graphic that we had drawn up where the hypothesis is that these MGUS, these monoclonal plasma cells, are producing an antibody. And then in some way, the antibody is going into the kidneys and triggering erythropoietin production from the cells that normally make erythropoietin in the kidneys. And of course, that would be a nice hypothesis. This is just totally made up, but this is one of our hypotheses. And we were going to try to test this hypothesis. And so to do that, we actually needed to do cell sorting of plasma cells. And there's one question, which is how do you tell an abnormal plasma cell from a normal plasma cell? And it turns out the groups in multiple myeloma, I think many people have seen these, but not everybody. So there are some other markers that might be expressed on plasma cells that can help distinguish normal and abnormal plasma cells. And so we did this with a couple of our patients. And you can see, of course, these are the standard markers for plasma cells, CD38 and CD138. And you can see these are basically on all plasma cells, normal and abnormal. But what's very interesting is that the patients who have monoclonal plasma cells or myeloma, but in this case, monoclonal plasma cells, they seem to lose CD19. You can see here, that's a little lower than the bulk population. And then they also, of course, have some other changes. You can see these 2 patients have lost CD81 quite dramatically. But what was nice to see is it seems like using this combination of more complicated markers, you can actually separate the different populations. And so here, as an example, we were able to separate the abnormal cells from one patient and the normal cells, and then send those for analysis. And what was very good is that you could then compare the normal plasma cells and the abnormal plasma cells. This is still ongoing, sadly. Hopefully I'll have that data soon. But the other thing that was very interesting is that one could then, based on those markers, also sort the bone marrow plasma cells. And we did this in collaboration with a group at Emory University. This is Dr. Jens Rammert and his postdoctoral fellow, Robert Kaufman. And they were able to sort the 138 positive, 38 positive plasma cells into little wells, of course, in a 96 well plate. And then they were actually able to identify, by basis of the unique antibody sequence, which were the monoclonal cells and which were the polyclonal cells. And again, this is just the same idea, but by sorting out the plasma cells, they could then do single cell gene expression analysis, as well as make the monoclonal antibody from the individual plasma cell. And this is sort of an interesting idea, right? So this is now, you could take the sequence of the heavy chain and take the sequence of the light chain. Now this would be a unique sequence, so the TEMPI antibody, and make recombinant antibodies. So that's what we ended up doing. And you can see here that, of course, it's a recombinant antibody, so there's only one. So it's this beautiful band, IgG kappa, which matches the patient IgG kappa. And then we asked what I thought was a very cool question. This is very new data, so nothing published here. But we then took mice and we injected the mice with the antibody. We tried to inject, this is actually quite a lot for those of you who have ever injected antibody. It's actually quite a lot of antibody because the patient concentration is actually quite high. And mice have about 1 milliliter of blood. And so we thought to try to get to the same concentration, we'd inject a lot of antibody. And I think what's very interesting, and this is of course very new data, so we have to repeat this, but look at what happens. This is mice that don't get any antibody. And this is mice, this is a group of mice that got an antibody that's just a non-specific antibody. This is our control antibody to control for the injection. And then look at this. These are the mice that got the antibody from the patient with the TEMPI syndrome. So the hemoglobin and the hematocrit go up. But what's fascinating, of course, is the white blood cells do not change. And I don't show them here, but the platelets actually also do not change. So a nice control that you're not just causing hemo concentration, and you're not just causing a non-specific effect in the mice. So I think more to come, more to be determined, but an interesting preliminary observation here that maybe the MGUS is also causing something. And then here is just a nice graph showing that in the mouse plasma, you can detect the human antibody. So even though it's cleared quite quickly, you can still detect. So I think actually we're coming right to the end now, but I'd like to, of course, say a big thank you to the audience. And we'll say a couple of words about these ultra rare diseases, which is, as you can see from the map, there's not very many patients. They're all over the world. The patient samples are very precious. And so if people, please, if anybody sees a patient with the TEMPI syndrome, please email, please reach out. I do have a small web page that I'm trying to get more and more information on about the TEMPI syndrome. And also, very importantly, try to collect serum samples and bone marrow samples, because if we learn what we should do, oftentimes it's too late once the patient has started on treatment to get those samples. So if there's ever a chance, please always feel free to reach out. And but also, yeah, look at your patients. And I think the take-home message on the TEMPI syndrome is whenever we start to see these unexplained super high levels of erythropoietin and telangiectasias, that's the time to think about the TEMPI syndrome. I think there are tons of people to thank, of course, across the world with all the different patients and people that have been in touch. I think I may have even still missed people, so apologies if I've missed people. But thank you very much. And as I said, thank you for the invitation.